thank you so much for the invitation. And so it was a last minute fill-in for Dr. Matt Levy, who called me yesterday. He had to go to a family funeral. And so I said, luckily I have some slides that I can easily prepare and give a talk. So my name is Kirsten Hawkins. I'm the section chief of Adolescent Medicine up at the hospital and assistant professor of clinical pediatrics. I'm also involved in medical education. I actually teach in the medical school a couple of different courses and small group sessions, and work with our fourth year medical students as they do electives and their acting internships as they're applying to their pediatric residencies. In my other hat, though, I'm working on a citywide project about healthcare transition planning for youth and young adults, and working with 5 different sites in DC. We're one of the sites. We're also working with Howard University, GW, and 2 sites through Children's National Medical Center. So it's been a really interesting. It's called a Learning Collaborative, and we were the first of 4 that are happening in the U.S. And so I'm going to talk a little bit about transition. I'm going to ask you all about your transitions. So are you guys seeing an adult physician? How many? Okay. If yes, what do you remember about your adolescent years in your healthcare? Did you leave your pediatrician by will or by force? Did they say you can't come back now that you're in college? Are you still seeing your pediatrician or family physician? Anybody?
Yeah, by will.
By will? Okay, you decided that you felt like you're too old for your pediatrician? Okay.
My mom is my pediatrician.
Oh, that's not good. Okay, so you've never seen anybody else? I know I've never seen my own kids. Okay. I say, how would you tell your mom if you had, something, what was it, there was something confidential that you wouldn't feel comfortable telling your mom about?
What?
What would you do if you had something confidential you didn't want your mom to know about? Where would you go get care? That you didn't feel comfortable talking to mom about?
I feel comfortable talking to her about anything.
Okay. There may be a time in your life though where you may not feel comfortable talking to your mom about something.
And there might be things your mom doesn't want you to say.
Exactly. So it's an interesting thought. I know I electively chose to leave my pediatrician and went to see an internist, probably much too young to see an internist, but I was 14 because my pediatrician was my friend's dad, and I didn't feel comfortable seeing him any longer, so I started seeing my parents' internist. And luckily he was a pretty great guy, and he was very proactive and was good with teens. He thinks now that I'm crazy that I do adolescent medicine. So I see teens through 21, occasionally 22. We have a 23-year-old grad student who still wants to see us, and we've been talking with him that he needs to move on. Oftentimes we know with youth that there's healthcare isn't necessarily continuous. So for a lot of youth, they may just kind of fall off their parents' plan. Now with the Affordable Care Act, we do have youth that are now covered through 26. So we don't have that gap of insurance now that we used to see. But in the past, we used to have youth who would drop off their insurance because they weren't in school full time, they didn't qualify for any federal plans, and they just didn't have healthcare, and they'd only seek emergency care. And so there's a lot of changes now within healthcare that we can actually start to see young adults and adolescents. And then kind of ask about that, whether you left actively or passively. So anybody ever heard of the concept of medical home? Great. So it's a community-based primary care setting which provides and coordinates high-quality, planned, family-centered health management and promotion, acute illness care, chronic condition management across the lifespan. And so the medical home has really taken off in the last 5 to 10 years or so. Certain offices or practices may be qualified as a medical home, meaning they meet certain criteria. They may get better reimbursement from health insurance companies for being a medical home. And so we've applied some of the quality improvement issues that have gone to medical home into transition care as well. And so what is healthcare transition? It's the deliberate and coordinated provision of developmentally appropriate, culturally competent health assessments, counseling, and referrals. So actually doing a better job of how we transition youth to healthcare. And I worked in college health for 3 years, and nothing like seeing a freshman in college and say, why do you have that sternotomy wound? So scar from here to here, and they have no idea. And I'm like, it's kind of something important that you're going to need to know to talk to a medical provider, or you can't just call mom to find out what medications you're on or what allergies you have. And so we're trying to do a concerted effort to really teaching our youth about how to better handle their own healthcare. So kind of like you get your driver's license, you don't get your license, you get what first? A permit or provisional license, and then you get your license eventually if you meet certain criteria. So we're trying to do a better job of actually teaching our youth how to access medical care and to start to give them more ownership of their care. So between 12 and 14 with our patients, we start to tell them, you're going to see the doc on your own. So at 12 and 13, we may have a parent in the room, and we're going to ask you the questions. And if you need help, mom or dad or guardian is there available for you. But by next year's visit, we're going to be asking all the appointment questions. And we expect you to know your family medical history and we'll give you some guidance, but by the time you're 16, if you have diabetes, you need to be knowing all of your medications, how to call for refills, how to schedule appointments. By 17, we want you to be able to make it on your own to your doctor's office, know how to get there, know how to call if there's a crisis, know how to manage your insulin, etc. So some components of successful transition, we know, is self-determination, so making sure that the patient's ready to do it. Person-centered planning, so making it centered around that family and that individual. Prepping them for adult healthcare, so giving them those tools that they'll need. Working towards independence. Inclusion in community life, so for especially with our patients with chronic health conditions, that we may need to incorporate other family members into their long-term health planning, and trying to start early. So in terms of transition process, we know pediatric care to adult care, and we're doing such a great job in pediatric care now that youth who didn't make it into adulthood are now. So our perinatal, so our infected HIV youth who were infected at birth are now in their 20s. We have a 27-year-old perinatally infected youth in our practice who follows the pediatric ID still. And they haven't transitioned them to adult care. I've transitioned her to internal medicine care. I did a good job there, but the ID folks haven't yet. Because the adult ID folks haven't been seeing youth with perinatal HIV, and so people never expected to see them live into their teens, let alone I have one perinatally infected HIV who has 2 kids of her own. So pretty remarkable compared to what we thought of HIV in the 80s. And so a lot of our youth are now living into adulthood with chronic illness. So what would you think a group of successful adults with disabilities would say the most important factor that assisted them in being successful in transitioning to adulthood? Thoughts?
Self-advocacy.
Self-advocacy, okay, love that.
Self-sufficiency.
Okay, that's a good one. So this was a study, they actually asked youth with disabilities with factors associated with resilience. And what do you think of these? Oh, it turned blue already. So involvement with household chores was the #1 thing that youth said. So they wanted to be just like their peers, they wanted to be like their other family members. And so that's whether it's cleaning their own rooms or making their own bed or having some involvement in the family, they felt that was the best factor for that they'd be able to be successful. So I have a 19-year-old patient, he's actually just turned 20 this month, that we've been trying to start his transition. And so he has multiple chronic subspecialist needs. And I'm still his primary care, but as issues come up, we've been having him see adult providers. So instead of the pediatric kidney doctor, he now sees the adult kidney doctor. When he had to see the gastroenterologist, we had him see the adult GI. He still sees his pediatric pulmonologist, but he knows in the next year we're going to find an adult pulmonologist for him. So we're slowly getting him ready to gear, and then we'll transition my care to an adult provider. And I saw him for his physical about 2 weeks ago, and all he talked about was that he has a girlfriend, and he went out on a date with her. And it's a kid who is fairly low IQ. He's been in and out of the hospital his entire life. He's on dialysis for kidney disease, multiple medical issues. And he wants to have a house, and he wants to have a family. And that's what he wanted to talk about. And he wanted to do things more independently. And so it was interesting, as his primary care provider, I could advocate for him and speak to the kidney doctor that he wants to do dialysis at home because he doesn't like going to dialysis center. It turns out he's not a candidate, but at least we had that conversation with his adult nephrologist that perhaps could he. And it was great for her to realize that he had, like, there were issues with him going to dialysis, so she could address them. So it was interesting that we could kind of talk about that. And he has a network of friends that are both disabled and non-disabled. So it was really cute talking about his girlfriend. He wanted to go visit her in Arlington. And we talked about he could do Metro Access to get there to see her. So in terms of, actually this goes back to kidney. Internal medicine, so nephrologists, doctors, kidney doctors, and they interviewed 35 of them. This was published a couple of years ago. And they're looking to see when they transition to the adult nephrologist or the pediatric nephrologist, the percentage of transition patients, and what they came with an introduction, so about 3/4 did. Less than half of the patients though knew their medications. Only a third knew their disease, which is pretty frightening. So these are kids who are 18 to 25. Transition questions asked patients, but then look at, so that's themselves asking questions, only 20%, but their parents or guardians were asking questions. So that's something that we need to flip around. And then the transition adults believed that they had had a difficult transition. So not quite half, but a good number felt like it was challenging to move. So the American Academy of Pediatrics, the American College of Physicians, so the internal medicine group, and the American Academy of Family Practice Physicians got together over the last few years to create a clinical report that targets youth. And they set up an algorithm structure to provide a logical framework with branches for youth that they do have special healthcare needs, but it's a framework for all youth to transition to adult care. And some some explicit guidelines about how to practice structure in the process, beginning at annual checkups, and then extending the transfer of care through into the adult care model, medical home. And it was an expert authority group that was from all over the US, different providers, and it was jointly authored, and it was published in last July, actually, and reviewed by a large and diverse constituency. And this is it. So it looks really confusing at first, so I'm not going to expect you guys to read it at all. But there's some chronic risk management and for some patients that don't have any needs at all. So you might just say at 12, we will continue to see patients in our practice through 18. So people have an idea of what's going to happen over the future. And that way the families can start making plans. Because some of my families, they don't know. They're like, nobody ever told us. I thought I could always see the pediatrician. Or it finally becomes an issue where they feel like they're too big to be in the waiting room any longer and they want to move on. Nice to see you. And or over here.
Sorry.
That's okay. So the Got Transition is a great website that was developed by Maternal Health Bureau funding and HRSA funding to actually create a centralized site where there is resources and tools and different links for both families, youth, and for providers as well. And it's a great website and jointly endorsed the new clinical report. And they're actually coordinating the learning collaboratives, of which I'm one of them. So it's basically a quality insurance practice where we're trying to improve our outcomes and identifying our patients with special healthcare needs. And we found that in DC we were doing a terrible job, unfortunately because we're a district and we're a city, but we get compared to states. So if you compare us to Baltimore or New York City, we probably would be fine. But we could compare to every state, and so our outcomes look terrible. And we look like we do a horrible job of transitioning our youth to adult care. And so we're making a concerted effort to do a better job in opening up communication. Now, some of the problem is trying to find internists and family physicians who are on the receiving end and trying to get them engaged. So we're actually doing a CME event tomorrow evening where we have over 150 people coming from out the city, and some physicians, some nurses, PAs, different providers, so we can talk about transition and try to reach out towards other people. And so we actually created a policy, a transition of care policy for our practice here. For young adults, we talk about at 18 what's different. You're the owner of your medical records at 18. Your parents can't ask us for medical records or for medical information without your written permission, and really trying to let parents know that. So when you go off to college and your parent calls and says, oh, I need their last immunization record, I'm like, actually, I can't give that to you. I need to have their written permission to do so. And that can be kind of like a, whoa, really? And so it's interesting. We could actually violate your HIPAA rights under HIPAA if we give that information out without your permission. And then we have a little information for parents so that they know as well. And we have it on our website, and we're trying to do a better job of making sure that parents and families know about this. And so I'm trying to be quick. Final thoughts? Any questions?
Oh, she has a question. Go ahead, Lisa.
Do you think that primary care is going to eventually be located in a hospital? Do you think we've seen the end of like community-based clinics?
It's actually moving away from that.
Really?
From the hospital base. So I'm not sure if you guys know about this. In the next year or so, our pediatric outpatient clinic will be moved away from the hospital. We're going to be moved up on Wisconsin Avenue. And so there's actually a move to do more community-based health centers. MedStar, which owns the University Hospital, has actually opened up a couple of primary care sites that are off-site throughout the DC and Maryland region. And so because we share, unlike Dr. Cook, we actually have an EMR as outpatient. And our EMR is actually pretty great in that it does, there's some not so good things about it, there are some good things, but there are a lot of adult medicine providers who are on our EMR. So for a lot of my patients, there's continuity of care. That adult doctor can see all the information there. I can send them a flag, say, hey, my teen patient's gonna start to see you next year. This is the information about their pediatric disease. These are their subspecialists, and it's very fluid. Now, if patients leave our practice, which some do, people go off to college or they move, we've actually created within the EMR, I work with our IT folks, and got them to create a clinical care summary that pulls together and extracts information from the EMR, so allergies, past medical history, immunizations, recent lab works, and it puts it all onto a couple of pages, and they can either put that on a flash drive or burn it to a CD or have a printed copy to take with them. So there's some benefits to at least in the outpatient setting, we have our EMR, which is really nice. And most primary care is out of the hospital. I mean, there are some places where health systems are buying primary care docs, like
I saw
practices.
MedStar just hired a bunch more.
Yeah, so but they're all community based. They're not at the hospital. Yeah, but which goes along in terms of it's so expensive to have the EMRs that if you're part of a larger network, that can cover a lot of those fees. So like Children's Hospital in DC, they have like a Children's Health Network. And so there's practices throughout DC, Maryland, Delaware even, that they pay a certain fee to belong to this network, and they get to then buy into a couple of then cheaper things, like they can buy their EMR cheaper that way, they get subsidized, or they can buy vaccines in bulk with a group, so it's less expensive to do the vaccines, which can be really costly actually, because we don't always get greater reimbursement from insurance companies. So there's that move too, so it's kind of like a balance of it. Hope I passed.
Yeah.
Yeah.
I don't know if I missed anything, but like, what's another disadvantage to allowing for people in their 20s and such to be continued on
With a pediatrician?
besides the ones you're saying, kind of like allowing people to be dependent on their parents and old
Well,
medical care.
there's some health issues that come up as people get older that as a pediatrician, I only saw patients through 21 that I don't have the ability to work with. So with my dialysis patient, I tell them, I'm like, Ryan, you're my only patient on dialysis right now. I don't know some of these complex issues that you're having to deal with, versus the internist is much better prepared for this. Or the congenital heart disease, or the coronary artery disease. I was in student health and I saw a grad student with gout. I hadn't seen gout since I was a third-year med student, so clearly not appropriate for the pediatrician to be seeing him. And so there's a lot of other health needs. Now, a lot of pediatricians don't feel comfortable seeing patients even over 18. And a lot of internists won't see patients unless they're 18, so then you have the issue there. I'm very comfortable, since I spent 3 years after my pediatric residency just working with teens, that I manage a lot of reproductive health. I do pap smears, I do a lot of GYN, I do a lot of other health management that a lot of pediatricians don't feel comfortable doing. And so it depends on the situation. Family medicine docs obviously see the whole spectrum, and so some youth will be with a family physician their whole life, but then they have to incorporate transition of care as well to the adult model. So we work with the Howard University Family Practice group, and they had to create a policy both for the pediatric side and their adult side, and so that the families know how things change when their youth turn 18. Question right there, right?
Yeah, I was just wondering about how we could stress the importance of transition of care to families that have children who are generally very healthy and don't have a lot of chronic health problems.
Right, so that's one of the things where nobody's really looked so much into transition of healthy youth. So we've been working a lot with special needs, patients with special needs, and that can be anywhere from asthma to ADHD for kids who have more complex medical issues. But in terms of primary health, that's where we're kind of moving towards for general kids who are and young adults who are fairly healthy, but still need routine screening, say pap smears at 21, or need to have their lipids checked between 18 and 21, so cholesterol screening. And how do we get those youth involved in not just seeing episodic care, like in the ER, urgent care, or student health center, and having a primary care physician. There's vaccines that we do now for young adults. We're boosting for meningitis now with Menactra at 16. Some of you may have been 14 when you had your first meningitis, and you may do need for another one. So trying to get youth to still seek a primary care provider. Yeah. So we're thinking about we do some risk assessments and transition tools we're using with the teens with special needs. We're thinking about how to apply those to so-called healthy, developing appropriately normal youth. Now, some of the issue too for our patients who are not developmentally appropriate to make their own healthcare decisions, so seeking guardianship. So I have a patient with trisomy 21 or Down syndrome who can't make his own healthcare decisions. And so at 17, I talked with his grandma, actually as his guardian, saying that you need to establish legal guardianship when he turns 18. You can't make healthcare decisions for him unless a judge grants you that ability to do so when he turns 18. And so that's eye-opening for a lot of our families as well, that they need to start seeking this support when their youth are 17. We had a youth who turned 18 in the hospital with spina bifida. She needed surgery. When she turns 18, she's the one who signs consent for surgery, and she refused to do it. She'd never done it before. Nobody ever told her that she needed to. Well, you're having surgery, you signed consent, and she was refusing. And so we had to get legal involved in the hospital about how to do the consent, because they weren't going to offer her, because that would be battery unless she actually signed consent. So we do run into challenges there too. For some youth who don't want to, they want to defer their care to a parent. I mean, many youth don't, and some do. And so you can do levels of medical decision making, and you can set up like certain situations of what information can be disclosed and when that won't be.
Do you think, sorry, the healthcare reform places more emphasis on primary care than on specialty care? Do you think there's going to be an impact on the number of physicians that are coming out of medical school in primary care, for example?
You know, it's interesting to see how things kind of like the tides change. So when I was in medical school in the 90s, there was a huge push for primary care. I was at school in Connecticut where I'm from, and we actually did a huge push for the state. It was a state school, so there was a huge investment in turning out primary care physicians. And then now you see kind of like the bell then swung the other way, and like nobody went into anesthesiology in my class out of 80 versus like here this year there's like 25. And partly that may have to do with the financial aspects, being able to pay back the student loans for Georgetown versus University of Connecticut, like the state school. So it'd be interesting to see kind of where things go there. There are a lot more though funding programs for reimbursement for primary care. So whether or not if you work in underserved areas or if you're willing to commit to your specific state, like Wyoming, I know a friend is a family physician there. Wyoming paid for him to go to medical school, and he had to practice for 4 years in Wyoming, which he was going to do anyways. He's from Wyoming, he was going to move back there, had an issue. And so it's, I think there's a lot of push, and even within pediatrics, there's a push for reimbursement for loans because we don't get reimbursed well from insurance companies. We don't get paid that well. We actually probably like the least well-paid specialty. And so there are some loan programs, whether it's for research or for, there's, hopefully it'll go through for some specialists even within pediatrics too, because there are some disparities in some specialty for pediatrics, like peds rheumatology, like there's very, very few, there's a huge issue. We have one practicing full-time in DC, and Dr. Mitchell, who's the dean of the med school, is the other pediatric rheumatologist locally, and he's the dean of the med school, so he doesn't have time to see patients, he sees patients 1 or 2 a week. So it's really challenging when like my patient this morning calls me rather than him with a rather complex medication issue that's not a medication that I write for, it's one that he writes for. So I'm like, okay, we've got to find out how to get in touch with him. So yeah, I don't know, it'll be interesting to see. I think there's a lot of money down